Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello, I am Mauricio Galizia, a cardiothoracic radiologist at the University of Michigan. Today, I will cover the basics of diagnosing arrhythmogenic cardiomyopathies using MRI. Before we dive in, I have no disclosures to mention. Arrhythmogenic cardiomyopathies are a group of diseases where the myocardium is replaced by fibrofatty tissue. This can lead to arrhythmias and an increased risk of sudden cardiac death. The first of these conditions was identified in 1982, described as a syndrome involving right ventricular dilation, RV wall motion abnormalities, ventricular arrhythmias, and fibrofatty replacement of the myocardium. Initially termed arrhythmogenic right ventricular dysplasia, it was thought to be congenital. Later studies revealed that myocyte atrophy happens after birth, leading to the updated term arrhythmogenic right ventricular cardiomyopathy, or ARVC. Research has shown that this condition has a genetic basis and can affect both the right and left ventricles, expanding the spectrum of the disease. Thus, the more inclusive term arrhythmogenic cardiomyopathies was adopted, encompassing three variants: right dominant or classical ARVC, biventricular, and left dominant, also called ALVC. These cardiomyopathies are linked to genetic mutations, especially in genes encoding desmosomal proteins. Desmosomes are cellular structures similar to rivets found in tissues under mechanical stress, like the heart and skin, and are composed of many proteins. Mutations in genes encoding different proteins lead to the different phenotypes of the disease. Diagnosing ARVC has been challenging. No single test can decisively diagnose it, prompting the development of the ARVC task force criteria, which includes major and minor criteria across categories such as structure and ECG abnormalities, arrhythmia types, and family history. Structural abnormalities can be detected by medical imaging, particularly through cardiac MRI. However, imaging alone cannot confirm ARVC. It is part of a broader diagnostic approach. To meet a major ARVC criterion through imaging, one must spot regional RV akinesia, dyskinesia, or desynchrony, alongside RV enlargement or decreased ejection fraction. Here's an ARVC case example. A 58-year-old woman experienced syncope while exercising. Although ischemic disease was ruled out, an ECG showed a PVC and right bundle branch block, and a stress test indicated an enlarged and hypokinetic RV. Cardiac MRI showed RV wall motion abnormalities and a decreased ejection fraction of 32%, meeting a major RVC criterion. Further assessment confirmed the diagnosis, supported by finding a plakophilin gene mutation. As understanding evolved, it became clear that ARVC is just one subtype among a broader range of diseases, prompting the creation of the Padua criteria. This framework includes updated and new criteria for diagnosing ARVC, ALVC, and biventricular variants. Let's explore how to use the Padua criteria for a suspected ALVC case. One key criterion is identifying late gadolinium enhancement in at least one LV segment, along with a pathogenic gene mutation. The enhancement should be subepicardial or mid-myocardial. It is often extensive and potentially circumferential. It is important to note that septal junctional enhancement is common and doesn't meet the criteria. Typically, the LV size is normal to somewhat reduced. Here's an LVC case. An 18-year-old man experienced palpitations and dizziness and was found in ventricular tachycardia at the ER. Initial evaluation for ischemic disease was normal, despite initially suspecting cardiac sarcoidosis due to increased septal FDG uptake on PET. Myocardial biopsies were normal. A cardiac MRI was then ordered, revealing a mildly dilated LV with low normal ejection fraction and subepicardial, almost circumferential late gadolinium enhancement involving the LV, suspicious for ALVC. Genetic testing confirmed this desmoplakin gene mutation, verifying the ALVC diagnosis. In summary, arrhythmogenic cardiomyopathies are genetic diseases characterized by fibrofatty replacement of the myocardium that manifest clinically with arrhythmias. Genetic mutations, often involving desmosomal proteins, are typically found. Imaging is a critical but singular component of the diagnostic criteria, with comprehensive assessments required to confirm the condition. The task force criteria initially aided ARVC diagnosis, while the PADRA criteria now encompass all phenotypes. Genetic testing is crucial, particularly for ALVC. Thank you for watching.